Luckily, I don't have to introduce either the speaker or the chair because they have introduced themselves yesterday. Yeah. You need to introduce, exactly. I mean, it's no formal thinking, I'm this, I'm that. Okay. Thank you, Manisha.
It's nice to see that everybody's woken up after last night and not suffering too much. शिव ये मेरे लिए नाम भी नहीं है. So I'm going to speak about obstetric bleeding. It is a very basic subject, but it is something that doesn't go away. However senior you are, however experienced you are, you still have to deal with obstetric hemorrhage. I work in a place called Aberdeen. I don't know if many of you know where it is. The dark blue part above is Scotland, and the red dot there is Aberdeen. It's a small city in the northeast of Scotland. It's not that small, it is quite a big city actually. It is famous for two things. It is famous for oil exploration, and because of that it is a very rich city. And it is famous for its granite. The whole city is built with granite. And this is the building that houses the medical college. It is the oldest and the largest granite building in the world. So, if you can imagine, the whole city has got such buildings all around, and most of the houses are built of granite as well. Even the new houses, yes, they are. Massive obstetric hemorrhage remains a major issue. Its incidence is 1.25 per 1,000 deliveries. And it is still one of the leading causes of maternal death all over the world. 80% of these deaths are preventable, and most of the hemorrhages are or should be preventable or controllable. When do we call it massive obstetric hemorrhage? Some people say more than 2 liters should be called massive obstetric hemorrhage. Some say 1,500. Some say when it needs more than 5 units of transfusion. And another criteria is need for clotting factors. It can be antepartum hemorrhage, can be intrapartum, or can be postpartum hemorrhage. Antepartum hemorrhage could be caused by placenta previa, could be caused by abruption, could be a marginal bleed, could be local causes, vasa previa, heavy show, or idiopathic. Management remains the same. You need to assess how much they have lost, you need to resuscitate, and you need to ask for help. However experienced you are, however senior you are, if it's a major hemorrhage, it's good to have help. For placenta previa, as you all know, it is classified according to the grade of placenta, according to the site of placental implantation. People worry about the placenta previa if it's anterior, because then the obstetrician has to cut through the placenta to get to the baby. And if it is posterior, then they tend to bleed more because there's no way of massaging the back of the uterus. Abruption, as you all know, causes concealed blood loss. And because the blood loss is concealed, there is no way of estimating how much they have lost, and these patients are often under-transfused. And if you are feeling lost, then it's a good idea to think about putting a central line in so that you know exactly where you are. and it can cause DIC. I'm sure you've all come across cases of abruption with major DIC. I've certainly dealt with a 17-year-old girl who came with abruption, and the obstetricians were trying to induce her. For 12 hours, they put her on Synto infusion. And through the night, she needed 8 units of blood and a large amount of FFP and platelets. And even after that, first thing in the morning, her hemoglobin was 5. And her mother was sitting next to her, and her mother said that each time she turns her head and looks towards her daughter, her tummy is bigger. So she was obviously bleeding hugely, but obstetricians were hopeful that she will deliver. So they were not wanting to do a cesarean section. Ultimately, she did have a cesarean section, and she lost 18 liters of blood and ended up with a hysterectomy. It is sad. A hard, woody uterus is pathognomonic of abruption. And they say that if the vertex is engaged, that means the placenta is not there in the lower segment. So that rules out a major placenta previa. If it's a minor or moderate antepartum hemorrhage, then there should be no signs of shock. There should be minimal pain or tenderness. The fetal heart sounds should be normal, but you still need to do a full blood count to estimate what the blood loss is. And I certainly would recommend cross-matching at that stage. You do need a venous cannula, and for obstetrics, I wouldn't do anything smaller than a 16 gauge. And you do need to monitor the baby with continuous CTG to make sure because in these cases, fetal loss is quite common. And it can happen quite suddenly, so it's a good idea to keep an eye on the baby. And you need an ultrasound scan to rule out a placenta previa and to assess the baby. If it's a major APH, then they say if the visible blood loss is more than 200 mils, that means there would be a large amount intrauterine as well. So the total blood loss would be major. They will have acute abdominal pain and tenderness. And because of the blood lost and the reduction in placental blood flow, they will have fetal heart rate abnormalities as well. Resuscitation is always ABC for anesthetist. So the first thing is always airway. Make sure the airway is fine and the patient is conscious and maintaining her own airway. And oxygen is always a good idea. Pregnant women should never be lying on her back. So we must always ensure that she is tilted. And if breathing is not adequate, then I would consider bag mask ventilation. With a major blood loss, I would definitely put in 2 16-gauge Fenflons. Keep an eye on pulse and blood pressure. Assess the loss and try and find the cause as soon as possible. Resuscitate with IV fluids, crystalloids, colloids, and try to give them warm fluids. You need to communicate, because if you are thinking major blood loss and the obstetrician is not thinking, then it doesn't work. So you need to tell each other what everybody is thinking. And you do need experienced people to be dealing with such cases. Experienced anesthetists, experienced obstetricians, and experienced nursing staff as well. And you do need a hematology and a blood bank to help you. You do need to keep a close eye on the blood pressure, on the pulse, ECG, saturation, urine output, central venous pressure and CTG monitoring. And you do need to investigate the full blood count, clotting screen, and fibrinogen levels. If blood loss continues, then you do need to check fetal heart rate and plan for an early delivery. Like I was telling you, my patient, they sat on that patient for 12 hours before actually deciding to take her to theatre. And by that time, her uterus was completely, it was a huge big bag full of bruises, and there was no way they could have salvaged that uterus. Coming to postpartum hemorrhage, the commonest cause is an atonic uterus. It can be due to a retained portion of placenta, can be due to a vascular episiotomy or a perineal tear, or a cervical tear, or uterine rupture. Even during a caesarean section, if the uterine incision extends, it can cause massive hemorrhage. And it can be due to coagulation failure or amniotic fluid embolism. So when do we run into trouble with these patients? We run into trouble when we fail to anticipate which women are going to bleed and plan ahead. When we fail to act on rising heart rate or falling blood pressure. When we have undertransfused, given too much crystalloids but not thought about giving blood. And when we have failed to detect that clotting is failing here. These women are young, fit women normally, so they do try and compensate their best. And it's often a good idea to put in a central line to make sure exactly what is happening inside. And at least in the UK, the biggest problem is when things are going wrong and senior staff are not there, results are worse. And when there is reluctance to proceed to surgery. After a vaginal delivery, if somebody is bleeding, it's hard to convince the obstetrician to take her to theatre and explore what is wrong. So if the heart rate is more than 100, if blood pressure is less than 100 systolic, or if obvious blood loss is more than 1500 mils, we should treat it as major hemorrhage and worry about it. It can be concealed because blood can be within the uterine muscle. It can be in the peritoneal cavity. It can be in the broad ligament. It can be paravaginal. So it may still appear to be concealed. In obstetrics, blood loss is almost always underestimated. There is amniotic fluid there, and blood is often on the floor. We had a very senior obstetric anaesthetist who's retired now, and she used to say that blood on feet is always a bad sign. If you have blood on the patient's feet, or if you have blood on the obstetrician's feet, it's always a sign of massive hemorrhage, even if the patient appears well. The most important thing is to keep calm, especially in obstetric theatres where it's obstetricians and nurses and midwives. They are not used to dealing with unwell patients as much as we anaesthetists are. So the most important thing is to keep calm. And to remember that tachycardia in a young patient is always significant. Uterine atony. As you know, where the placenta is attached is a huge big raw area. If it doesn't contract, if the uterus is a big floppy bag, it will bleed and it can pour out blood. So you have to be very aggressive in management, and you have to be proactive with oxytocin. You have to look for risk factors. Somebody who's been in labor for a long time, somebody who's been on oxytocin infusion, that uterus is going to be resistant to contraction. Somebody who's in shock. And I was taught you should be aggressive, you should try and look into the wound, see what the uterus looks like, and if you can't make out, ask the obstetrician. Communicate with them. If things are going wrong, then obstetricians often go silent And that is always a sign that they are focusing, so they're not telling you that things are wrong. And that's when you really need to ask them. So don't leave them alone, pester them, keep asking, is everything okay? Is the uterus contracted? If it's minor PPH, less than 1500 mils, then again look after the airway, lateral tilt, breathing, and start your resuscitation. Assess the loss and look for the cause. If it's major PPH, where your loss is more than 500 mils and your patient is already tachycardic, you need to continue with resuscitation. You need to keep a very close eye on them, and you need to investigate, and you need to get them to stop the bleeding. You need to exclude other causes, make sure there is no traumatic bleeding, and especially if the patient has had a vaginal delivery, if the bladder is not empty, it does stop the uterus from contracting. So make sure the bladder has been emptied. Excuse me. The obstetrician should be doing bimanual compression by this stage. And you should be getting your pharmacological measures organized. And then they should be planning for their surgical measures. I'm sure you're all familiar with these. Oxytocin at delivery, whether it's a cesarean section or a vaginal delivery. If that doesn't work, we would give a second dose of oxytocin and start an infusion. You can give ergometrine. It's a nasty drug. So personally, I like to dilute it in 10 mils and titrate it. And you can give prostaglandins. I don't know what makes are used in India, but carboprost is the commonest one used there. Prostaglandins should never be given intravenously. Obstetricians are taught that you can inject it into the uterine muscle, but uterine muscle at delivery is very vascular, so it is going to end up as an intravascular injection, and you should never let them do it. It should be a deep intramuscular injection, and you can repeat it every 15 minutes to a maximum of 8 doses. You can also give misoprostol PR, which is very effective, and with the slow absorption, it does have a prolonged effect as well. And you should, although there is no evidence at the moment, tranexamic acid is still quite a popular choice, especially since we are used to using tranexamic acid elsewhere. If nothing else is working, I would definitely give tranexamic acid, a bolus of 1 gram and an infusion of 1 gram over 8 hours. And then you need to get them to think about surgical measures. You can pack the uterus. Balloon catheters are very popular these days. Do you get them here as well? Sorry? Yeah, no, it's what we have. It's It's like the balloon catheter used for esophageal varices. It's a massive balloon that takes 300 mils of fluid. Yeah. So that can be used to tamponade the uterus. And a B-Lynch suture, or some form of a B-Lynch suture that helps the uterus to contract. And if nothing else works, then you need to think of arterial embolization of the iliac arteries or the uterine arteries, or ligation of uterine arteries or internal iliac arteries. And if nothing else works, then a hysterectomy. But usually by the time it gets to a hysterectomy, your patient would have lost a large amount of blood and would definitely be coagulopathic as well. Then we come to retained placenta. If the placenta is not delivered within 30 minutes of active management, or sometimes after a vaginal delivery, they leave them alone to slowly pass the placenta, and if it has still not been passed after 60 minutes. It happens in 1% of all deliveries, and the recurrence rate is about 32%. It can be due to a full bladder or uterine atony or uterine abnormalities or the placenta being stuck. How do we manage this? Again, we need to assess the blood loss first, and if they have lost a significant amount, then resuscitate them, get a full blood count done and cross-match. We do need to keep a close eye on them. Most of the times, if the placenta is stuck, then they do not bleed. But if it is not stuck to the uterine wall, but is just retained inside the uterus, in those cases, they definitely do bleed. So you do need an oxytocin infusion as well, and you need to take them to theatre as soon as for a manual removal of placenta. In theatre, you would continue your resuscitation. Make sure normovolemia is restored before you anesthetize them. How you anesthetize them will depend on the amount of blood they have lost. If they have lost a significant amount of blood, then they are likely to be coagulopathic, in which case we do not want to stick a needle in their back. And if you have doubts, if you're not sure how much they have lost and what their clotting status is, it's safer to go for a general anesthetic. From a general anesthetic point of view, this is a woman who's just delivered, so she's just at as much risk of aspiration as she was before having the baby. So I would still do a rapid sequence induction. So the most important thing is to anticipate which patients are at risk of major blood loss and make sure you're prepared with all your pharmacological equipment and surgical plans. So you must identify the patients who are at risk, the placenta previas, the patients with, especially if it's a placenta previa with a patient who's had a previous section, because the placenta stuck to the scar is always bad. With increasing maternal age, there is a higher risk of hemorrhage. With prolonged labor, there is a higher risk of hemorrhage. Patients who have fibroids, because of the uneven uterine surface, they do tend to bleed a lot more. With multiple pregnancies, where the uterus is bigger than usual. And if it's a caesarean section done in the second stage of labor, that is your fully dilated patient who's had a trial of forceps and then going for a caesarean section, again, these patients are more likely to bleed. Early diagnosis is the key. And like I said, however experienced you are, however senior you are, it's useful to have an extra pair of hands. You need to restore circulating blood volume. You need to check full blood count, clotting screen, and cross-match. Our policy is 6 units of blood. And it's useful if you have got some equipment to check the hemoglobin level by the bedside rather than wait for lab values. So whether it's a HemoQ in theatre or a blood gas machine that you have faith in. And you need to have 2 16-gauge Venflons in. And if in doubt, consider CVP monitoring. Rapid IV fluids, cell salvage, and in UK at least they have moved to using a 1-1-1 transfusion, which means for every 1 unit of packed cells, you should be giving 1 unit of fresh frozen plasma and a unit of platelets. And you have to plan what you're going to do for post-op, because these patients are going to need intensive monitoring. So whether you're going to put them in intensive care unit or just some kind of a high dependency unit where they can be looked after. Adherent placentas are becoming more and more common, especially in the West. I don't know if it's happening here as well. There is need for early diagnosis and management, and the mortality from placenta previa accreta is mainly due to failure to diagnose it, especially in women with previous caesarean sections. Accreta is when the placenta is stuck to the uterine muscle. Increta is when it's invasing the uterine muscle. And percreta is when it's perforated through the muscle and is invading structures around it, like the bladder or rectum or even rectus sheath, I've seen. You need an antenatal diagnosis, which is usually done by ultrasound, or a clinical diagnosis at the time, when the placenta is not separating even after 20 minutes, which happens 1 in 1,000 cases. And retrospectively, you can come to a pathological diagnosis when after a hysterectomy you find that the pathology report comes back as absent decidua between the chorionic villi and myometrium. The risk factors are again previous caesarean section, placenta previa, patients who've had previous uterine curettage, patients who've had a few miscarriages or terminations of pregnancy, other forms of uterine surgery such as fibroid surgery, endometrial ablation, patients who have endometritis, increasing age, and for some reason IVF pregnancies are associated with accretas as well. The risk seems to increase with the number of caesarean sections. You probably don't see so many caesarean sections in India, but certainly in the West we do come across patients who've had 4 or 5 caesarean sections. And as you see in this graph, after 4 caesarean sections, the risk of placenta accreta is 70%. When they do an ultrasound, they should be able to see placenta accreta. There should be vascular lagoons visible from 15 weeks of pregnancy. There should be loss of retroplacental hypoechoic area with disruption of uterovesical serosa and extrauterine placental parenchyma. They often do MRI scans to confirm the diagnosis, and it will also show you the degree of invasion. Like here you can see that is the bladder, and you can see things coming into the bladder. So that's the placenta grown into the bladder itself. And then there is new vessel formation there, which obviously is going to cause massive hemorrhage. These cases are very challenging, so you do need to plan well ahead with a multidisciplinary team. You need a radiologist to diagnose the case in the first case. You need an obstetrician who's completely ready to deal with it. You need an obstetric anesthetist who's experienced at it. Certainly in the West, obstetricians do not do major gynae surgery, so you need a gynecologist who is familiar with pelvic surgery. And an interventional radiologist, because these patients are going to bleed, and it's a good idea to have balloon catheters put in advance. So you do need to consent the patient, and you do need to explain to them what the risks are. I would definitely go for a general anesthetic, because it's easier to deal with major hemorrhage when the patient is asleep. Cell salvage is a good idea, and you will need lots of blood and blood products. The interventional radiologist should be putting in balloon catheters prior to taking this patient to theatre and checking the position of the catheters. They usually proceed with a midline incision rather than a phalansteal incision. And if it's invading at the back or the bladder wall, then it could be causing obstruction of the ureters as well, so they often need to have ureteric stents put in. They try and remove as much placenta as possible, but obviously they don't want to be operating on the bladder wall or the rectus muscle. So they do tend to leave whatever is not coming off easily. And hysterectomy is often required. Leaving the placenta in situ is obviously a better idea than doing major resection, but it can cause bleeding at the time. It can cause bleeding later on. There is a risk of infection or sepsis with it as well. It can cause coagulopathy as well, and it can cause recurrence. Obviously, this kind of situation is associated with adverse outcome, but more than 95% of the patients have risk factors, and that is why it should be anticipated and diagnosed antenatally. And like I said, you need a multidisciplinary approach. That's not a very good picture, but that's what Aberdeen looks like on a nice day. Any questions?
The dose of oxytocin you didn't specify. How much do you give at your center?
The ED95 of oxytocin is actually 2 units. However, it's difficult to convince obstetricians to do that. So we normally give 5 units, diluted and given slowly, and give it a few minutes to work before you repeat it.
And what about infusion thereafter after the bolus? Do you give an infusion or just leave it at that?
We give an infusion if the obstetrician asks for it, or if it's a high-risk patient where we're worrying about it, then we would definitely give an infusion. It varies from hospital to hospital. Some hospitals put in 30 units in a bag and run it over 4 hours. Others do 40 units in a bag. So it is whatever your local policy is.
40 units in 500 ml or 1 liter bag?
500.
Is there established uroanemia before you use the patient, which is always not possible. You have to do the resuscitation and the anesthesia simultaneously in most of the
Yes, absolutely. But when you're going to scrub for a spinal, you can make sure you've got 2 Venflons in, and you can make sure your assistant is running in.
not possible to establish uroanemia before you start.
Yeah, but you do your best.
Yeah, the other thing, in these patients, most of the time it is probably better to go, like she said, for general anesthesia, because they can really spring surprises sometimes. The way they behave is quite unpredictable. They may not bleed also, and sometimes they bleed so massively that you can hardly catch up with it. And, obstetric hemorrhage is the leading cause of maternal death in India. It's probably the number 10th or number 11th cause in UK. But in
It
India...
is not. It is actually number 3.
Is it?
Even now,
That's
yes.
Even now. I think in US it's some way down, 10th or 11th on the list. But I'm not sure. But in India it is number 1. And out of the, I think it's a 200 odd per 100,000 live births. I think more than 100 are because of obstetric hemorrhage.
And it's really sad because this is something that can be controlled and managed.
Absolutely. And there was some time back I'd read a report, and the major cause of this is an absence of anesthetists at the district level hospitals. And these patients, there is a delay in transfer to a higher center. And many of them, most of them in fact, more patients die because they can't reach a hospital. They die during transfer, even before they reach the hospital. So it's a very, very massive and a very, very sad story out here. And after all these years, we are still sort of struggling with it.
Unfortunately, in the West is going that way now. The government is promoting home deliveries with the risk of, with an unknown risk. They do say that high-risk patients should not be delivering at home, but who's going to anticipate?
Yeah. So because of, yeah, because of this particular reason.
Yeah. No, that makes complete sense.
Yeah, it's just unfortunate that the hospitals are also not always, especially the district level hospitals, are not fully equipped to handle these patients. That probably a home delivery is cleaner and less likely to cause infection, but still to bring down the maternal mortality. Just one thing I wanted to ask you, Manisha. Read some time back that blood fibrinogen levels are a predictor of postpartum hemorrhage in patients. Do you guys do routine fibrinogen levels in pregnant patients in UK?
No.
No.
I mean,
Are there any recommendations about it? I mean, I don't know.
Well, actually, I was at a transfusion meeting recently, and hematologists are now recommending that patients coming for all major surgery, whether it's orthopedics or general surgery or obstetrics, should have fibrinogen levels done in advance. But at the moment, we're not doing it.
We're not doing it because the correlation is quite significant according to the last study. I think it was from UK only. The study
it was actually from our center.
Okay, right.
And they actually invested in ROTEM. And they now do ROTEM study because it tells you exactly when you need to actually do that. Right. And now they actually have fibrinogen concentrate within the theater complex. Okay. And they have actually reduced the amount of blood used by the unit. And that is actually saving because each unit of blood in UK can cost anywhere from 300 to 5,000 pounds. That is nearly, quite a lot. I mean,
that's
quite a lot of money, 30 to 50,000 per unit. So
that study is still going on.
OBS2 study on fibrinogen.
But fibrinogen concentrate is not available commercially. It's not available outside.
Oh,
the
you
study.
can give some.
Yeah. It's only available
if
for
you
the
know a
purpose of
patient,
study.
if you know a patient has low fibrinogen, maybe you can arrange for some cryoprecipitate or something.
But that's exactly what they're
Pre-operatively.
saying, that they worry so much about transfusion and CJD and all
yeah,
that.
yeah,
So
if you're not
cryo is quite a dangerous thing.
Right.
So fibrinogen should be available.
it should be, yeah.
I had a question.
Yeah.
You mentioned that ergometrine is a nasty drug. Would you like to use it if the oxytocin fails as the first choice, or would you use a prostaglandin before?
No. It is a nasty drug, but prostaglandins is nastier. So yes, I would use ergometrine first.
But I have read in certain papers where they are advocating ergometrine to be the last choice because of the effects on the heart as well as the cerebrovascular accidents associated with it. Prostaglandins would probably be. This is for the freelancer friends basically, because they have to.
Certainly in the UK, all guidelines at the moment say that if oxytocin hasn't worked, the first line of drug of choice is ergometrine. And prostaglandins come after that.
As a second.
I would like to add to it. I think in preeclamptics, the choice goes.
Yeah, in hypertensive patients, you wouldn't give ergometrine, but otherwise you would.
Thank you.
Yeah, even the Society for Obstetric Anesthetists, SOAP, they also, the second line drug is ergometrine, the American Society.
Ma'am, second dose misoprost we usually don't give here. IM misoprost. Like, it's kind of contraindicated. Do you use it?
Yes, you can repeat it up to 8 times.
Carboprost.
Carboprost.
Carboprost. Prostadin can be repeated, yes. But you should use the 250 microgram dose, or even 125 microgram, because our patients are smaller. Many times 125 micrograms also works in these patients. So if you have a very small patient, 125 microgram, wait for 15 minutes. If it doesn't work, you can repeat it. 15 minutes, I think you have to
Have you
give.
seen bronchoconstriction?
You'll be, yes.
Pardon?
Okay, that's a thing.
Bronchoconstriction, not really, not very often. Unless a patient is asthmatic or something, and at that moment, I think if the bleeding is heavy, that's more of a problem than bronchospasm, unless it's happening like. Right
If
there.
you give it intravenously, then you definitely get bronchospasm.
Yes. Right.
So that's
With
why.
IM, not so common. Actually, the misoprost, I don't know why people don't use it more often, that sublingual or put it in I have not seen the obstetricians asking for it. No, I mean like on table. Can you use it on table? Put it in the mouth, no? No. Yeah, it's just that maybe if they're operating, it's difficult to put it. But
Okay, guys, so we'll move on to the next topic. This is a bigger topic, and Pallavi is going to actually talk about perioperative care in obstetrics, coagulation and other conundrums. Okay, it's a very, very interesting topic, and she will take you through quite a few scenarios. Well, it is actually one patient, but a good story. Thanks, Pallavi.
A very good morning to everybody. And thank you, Taz, for giving me this wonderful opportunity to speak in front of such a learned crowd. Okay, so let's get on to the case. This is your patient for today. So she's a 24-year-old primary gravida with a BMI of 35, 38 weeks in labor, blood pressure of 150 by 100, with headache and visual disturbances, and there's no history of previous hypertension. So your diagnosis is preeclampsia in an obese patient. Hypertension in pregnancy is classified as gestational hypertension, which occurs after 20 weeks of gestation with no proteinuria. Chronic hypertension is one which exists even before pregnancy and detected before 20 weeks. Preeclampsia and eclampsia is high blood pressure detected after 20 weeks and associated with proteinuria. Preeclampsia is associated with, it's classified again into mild and severe, where you have 3+ and 5+ protein in the urine. And preeclampsia superimposed on chronic hypertension, as the name suggests. So there's certain facts about preeclamptic toxemia. It's a multisystem disorder of pregnancy. 10% of pregnancies do suffer with preeclampsia. The incidence is higher in developing countries. It's a second leading cause of direct maternal death, and it's associated with the triad of physiological derangements of vasospasm, plasma volume contraction, and local DIC. The PET is a disease of theories. The exact cause has not been found yet, but the placenta and the abnormal cytotrophoblastic invasion is found to be the major causative factor. There are changes in the endothelium too, which are seen as increased vascular tone, permeability, and fibrin deposition, and release of vasoconstrictors and procoagulants. And in the blood, we have reduction in platelets, prostacyclin, and antithrombin 3, an increase in the thromboxane A2. All these effects lead to DIC and hemolysis. So the overall effect is it affects the uteroplacental circulation and causes insufficiency. Eclampsia comes from the Greek word eklampsis, which means sudden development. The sudden development of generalized tonic-clonic convulsions with or without raised blood pressure or proteinuria with no identifiable cause. These convulsions can occur antepartum, intrapartum, or postpartum. And the mainstay treatment of this is urgent delivery and BP control. The other aspect of our case today is obesity. It's in pandemic. Females are more affected than males. Obviously, rising BMI causes decrease in life expectancy. And the additive effects of pregnancy and obesity poses significant challenges to both the obstetrician and the anesthetist. We've discussed about obesity much in detail. I'm just going to focus on the maternal implications and the fetal implications. There's increased incidence of gestational diabetes and preeclampsia, chronic hypertension, increased incidence of PPH, risk of thromboembolic events. With regards to it causes wound infection and breakdown, endometritis, increased risk of uterine rupture. These patients do not have a very smooth course of labor, so there's increased rate of induction. The induction is often unsuccessful. They land up more in cesarean sections. And there's increased chances of postnatal depression, which has found that they don't tend to lose the weight they have gained during pregnancy. Fetal implications are also massive. There's increased incidence of miscarriage, fetal abnormalities, and because of the abdominal pat of fat, there's a suboptimal view at ultrasound. There's increased premature delivery and overall increase in the fetal mortality and morbidity. Now, this patient is admitted to the labor ward. We're going to subject her to investigations like complete blood count, mainly platelets, liver function test, renal function test, electrolytes, PT-INR, and fetal monitoring. The mainstay of the medical management is to get the blood pressure down, systolic less than 150, diastolic less than 80. We have a lot of drugs to choose from, but labetalol remains the first line of drug, which is obviously contraindicated in asthmatics because of its both alpha and beta action. Nifedipine is still being used at quite a few centers, but its sublingual use is condemned. Methyl dopa, atenolol, metoprolol, all these drugs have been used in the treatment in the antepartum period, but it causes IUGR. And magnesium sulfate remains another drug of choice for the treatment of severe preeclampsia and the prophylaxis of eclampsia. It causes 50% reduction in seizure rate. The collaborative eclampsia trial regimen is followed in most of the places, where we give the loading dose of 4 grams IV slowly over 5 to 10 minutes and followed by an infusion of 1 gram per hour for 24 hours. How does magnesium work? It causes relaxation of uterine and vascular smooth muscles. It increases the uterine blood flow, and it decreases the CNS irritability and decreases the likelihood of seizures. So for how long do we continue this magnesium infusion? It's continued for 24 hours postpartum or 24 hours post last seizure, whichever is later. However, one of the recent papers showed that it can be stopped 12 hours postpartum. How do we monitor this patient? Magnesium is excreted through the urine, so urine output. It causes effects on the CNS, so deep tendon reflexes. It affects the respiratory center at very high concentrations, so respiratory rate and oxygen saturation. And serum concentration is to be measured, where we maintain therapeutic levels between 4 to 7 millimoles per liter. Now, what if this patient needs GA? What implications does magnesium have? It decreases the activity at the neuromuscular junction, mainly by decreasing the presynaptic release of acetylcholine and also reducing the post-junctional membrane sensitivity to acetylcholine. So the overall effect is enhancing the neuromuscular blockade, which is produced by the NDMRs. Magnesium-induced relaxation of uterine and vascular smooth muscle tone causes uterine atony. So often you find the uterus flabby, so there's increased bleeding after delivery. There's enhanced effects of opioids and sedatives, and also it readily crosses the placenta, so you have neonatal hypotonia at birth. The story still continues. This patient has been started on magnesium sulfate on arrival. Antacid prophylaxis has been given. Blood pressure now is 140/90. And 2 hours, the blood sent then have revealed a platelet count of 90,000 per cubic millimeter. So what's your diagnosis here? It's thrombocytopenia. Thrombocytopenia in pregnancy occurs very commonly. Normally it decreases by 20%. This is mainly because of hemodilution and because of increased platelet destruction. So you have more mature, you have the immature and larger platelets in circulation, but the overall effect is that these platelets are capable of causing the coagulation. 7% have counts less than 1.5 lakhs. 0.5 to 1% have counts less than 1. So basically, counts less than 1.5 lakhs has been comes under the category of thrombocytopenia. This thrombocytopenia may be static or dynamic. Dynamic is important for us because patients who land up in PET or ITP usually have a dynamic, ever-changing platelet count. The differential diagnosis for thrombocytopenia goes as this: gestational, which accounts for 75% of thrombocytopenias; ITP, which accounts for 5% of pregnancy-related thrombocytopenias, followed by TTP, which is the thrombotic thrombocytopenic purpura. Nevertheless, severe preeclampsia do present with thrombocytopenia. HELP syndrome, which is a severe form of preeclampsia where you have elevated liver enzymes and low platelets and increased LDH because of hemolysis. The other miscellaneous causes include HUS, acute fatty liver of pregnancy, DIC, SLE, HIV, and drug-induced. This patient is now getting regular contractions and she's in severe pain. She's requesting for an epidural. So how are we going to proceed? We follow the routine approach towards any patient, which includes history, examination, investigation, which will lead us to a likely diagnosis. Is it okay to proceed with that? Is the epidural really necessary, or whether she can manage with the other alternative methods of analgesia? And obviously discussion with the patient regarding the risk versus benefits. Past medical surgical anesthetic history, as usual in other cases. For us, thrombocytopenia, when it was first discovered, it is important to know whether she's suffering with ITP or TTP, or whether it's related to the hypertension diagnosed. History of easy bruising or evidence of petechia or ecchymosis or any active bleeding from any of the sites would obviously contraindicate our use of regional. Current medications like sulfonamides and like quite a few drugs do have interactions with the platelets. Family history obviously will lead us to some diagnosis. Previous investigations and current problems. We would concentrate on the heart rate and BP charting. Our airway evaluation would also go hand in hand, where we would look for pharyngolaryngeal edema, examine the skin for purpurae, bruising, and petechiae, and ensure there's no clinical evidence of bleeding. Detailed systemic examination should also be done. So it leaves us with the investigation where we need to repeat the FBC with platelet counts. Bleeding time is not reliable because there's a lot of inter-observer variability with this test. Clotting screen, you would do the APTT, PT, and fibrinogen, use and ease, creatinine, liver function test, and urine analysis. If we are lucky enough to get a TEG in our centers, which I think would be a luxury in smaller setups, the maximum amplitude of more than 53 millimeters corresponds to a platelet counts of roughly 54,000. Quite a few papers have suggested that a count of 75,000 and more is okay for epidurals to be done. Platelet function analyzer is a point-of-care investigation where the agonists like epinephrine and ADP are added, and the closure time of the collagen, which has a small aperture, 150 micrometer aperture, is tested. So this is a normal TEG where you have the R, this is the reaction time. K is the time from the onset of bleeding to where we start getting the coagulation. Angle is the alpha angle, where it is roughly around 20 degrees. And MA stands for the maximum amplitude. So the management here is we would identify the likely indications for epidural, the diagnosis. We would explain the risk versus potential benefits to the patient. Whereas the risk is 1 to 1 in 150,000 for epidural, and the next figure for the spinal. Consider platelet transfusion if the platelet counts are dropping further, obviously in consultation with the hematologist and the obstetrician, and we would obviously discuss the alternative methods of analgesia with the patient. Certain facts about RA is that its safety is well documented. Platelet counts of more than 75 have been found to be safe, but I think in UK the practice is different. Madam told me that more than 1 lakh is considered as the absence of coagulation abnormalities, helped DIC obviously would contraindicate the use of RA. Early epidural in labor always benefits. it decreases the hypertensive response, and it decreases the cardiorespiratory workload. And we can also use it as a rapid route for the initiation for labor. IV remifentanil PCA is used if RA is contraindicated. I don't think so. It's available here. It has been found that the incidence of hypotension is less, as you would see in the other normal parturients. And vasopressors like ephedrine or phenylephrine are the drugs of choice. This is the same slide where I was saying about the counts. Less than 80,000 people some people would use regional anesthesia, but they would prefer to use spinal instead of epidural. And low-dose aspirin is not a contraindication to RA. And resolution of block should be monitored very closely. So this patient, obviously we'll have technical difficulties, like it's difficult to insert epidural in these patients. There is increased risk of the epidural catheter becoming displaced. Like when we change the position from the crouching position to the straight position, the epidural catheter usually comes out. There's inconsistent reports of increased risk of inadvertent dural tap, higher than expected block levels because of miscalculation of the total volume given, and there's low risk of PDPH because of increased pressure. Now, we've cited an epidural at 1 with the help of a normal length epidural needle, which is the common finding that we need a normal length epidural instead of a long length in most of the obese patients. And labor is augmented with the oxytocin drip. The benefits of epidural are many. The superior pain relief. It has excellent control over hemodynamics, where you have 20% drop in the blood pressure with small reduction in SVR and maintenance of cardiac index. The Doppler velocimetry has shown that there is decrease in the systolic to diastolic flow ratio by 25% as compared to the non-preeclamptics. There's vascular resistance and relief of vasospasm. And there's increase in the intervillous blood flow, which is very important in improving the uteroplacental circulation. This is the same thing I was talking about. This rapid initiation of anesthesia can be done. And the previous concerns of giving fluids and sympathectomy with the epidural have found that they have no role. There's no increased incidence of pulmonary edema with giving vasopressors or giving fluids in these patients. This patient now develops fetal decelerations, and the obstetrician has decided to go for an emergency LSCS. Blood pressure is 140 by 100 and platelets is 90,000. The same age-old controversy whether to go in for an RA or for a GA. RA, obviously with epidural, we would prefer it in non-urgent setting. But spinal is still preferred by most because of its rapid action and reliable, and it's quite reassuring. Epidural can be used for initiation and also for top-ups for analgesia. With GA, we are going to encounter more incidents of swollen airway and respiratory complications like rapid desaturation, but it's mainly used when regional is absolutely contraindicated, like coagulopathy, DIC, or HELP. We've discussed about obesity yesterday, but these are few things which we would definitely want to have: a large operating table, manual handling equipment, adequate staff, electric beds, large gowns, wide BP cuff, large compression stockings, long spinal and epidural needles, lucky enough to have ultrasound help and monitors. So everything is large. Regional anesthesia, we would... people prefer to go either with a single shot spinal, or they like to give a small dose of spinal or extend the epidural. A few points we need to remember is left uterine displacement should always be maintained. Big panenculus retraction can lead to sudden hypotension, so that should be looked out for. Ramped up position to maintain the FRC and supplemental oxygenation. Again, we need to control the hypertensive response with GA. Pharyngolaryngeal edema, the larynx can look pretty much like this. There's increased incidence of aspiration, neonatal depression, and the magnesium and the CCBs interacting with the NDMR should always be looked for. This is the ramped up position, which is being used with the help of multiple sheets. This decreases the angle between the laryngeal and the pharyngeal axis. The whole idea is to get the head above the chest level. Lucky enough to have a ramp if available. That is how the ramp would be placed. A few clinical pearls of epidural in obese patients. Ultrasound guidance helps. If you don't peep, you may shriek. Some people prefer to, there's some studies which mention that a little bit more left inside would help, 3 centimeters, 3 to 4 centimeters. And obese patients have a lower epidural analgesic requirements as compared with the other normal parturients. Analgesia is multimodal. Paracetamol should be used in caution with raised LFTs. NSAIDs are contraindicated in coagulopathy and renal insufficiency. Opioid PCAs, TAB blocks, ileoinguinal block, ileohypogastric block. Should never forget thromboprophylaxis. And postpartum care should include restricted fluid infusion of around 70 mL per hour and BP control. This patient should be nursed in the HDU or ITU, preferably if CPAP, if the patient has OSA, by a trained person, nursed in a sitting position, post-op physiotherapy, early mobilization, and oxygen. And the patient should ideally have a pressure-relieving mattress or a waterbed. The story still continues. This lady has had an uneventful cesarean section under epidural. She's got an indwelling catheter for post-op analgesia. The baby is doing well, and she develops calf tenderness and shortness of breath on exertion. So have you missed something? What is it? Yeah, so we've missed thromboprophylaxis in this patient. She's developed DVT. So there's increased risk of venous thromboembolic disease, which could be either DVT or PE, and it's the major non-obstetric cause of maternal mortality. DVT has an incidence of 0.1 to 1%. It's equally distributed both in the ante and the postpartum period. In the antepartum period, it mainly presents as DVT, and in the postpartum period, it mainly presents as PE. 40 to 60% of PE occur 4 to 6 weeks after delivery, which is quite a high incidence. There are certain facts about DVT that mainly it occurs on the left side in pregnancy. Pelvic veins are also affected, but they may not be picked up on routine testing, and ovarian vein thrombosis can also occur. Why the risk is greater in pregnancy? Because pregnancy is a prothrombotic state. There is increase in the level of all the coagulation factors except 11 and 13. There's increased levels of the plasma inhibitors, which decreases the fibrinolysis, and there's decrease in the levels of the natural anticoagulants like protein C and protein S. So this is the risk assessment form, which is adopted from the NICE guidelines, where there is, the patients are risk stratified into high, intermediate, and low. The patients who've got a single episode of VTE previously and history of thrombophilia or family history automatically go into the high risk category. Patients who've had medical comorbidities or undergo any surgical procedure with single previous VTE and thrombophilia go into the intermediate risk. The bottom square shows patients who have aged more than 35 years, obesity, parity, more than 3, smoker, gross varicose veins, preeclampsia, multiple pregnancies, all fit into the low risk categories. But when you have more of these factors in one patient, they enter into the intermediate risk category. So these are the guidelines which are followed in the Royal Aberdeen Hospital where Manisha ma'am works. All women there are given Flowtron boots. Early mobilization and hydration is followed, and dalteparin is given until fully mobile up to 7 days. Whereas all high-risk patients receive the above measures in addition to TED stockings. The prophylactic measures, these are the NICE guidelines which have classified according to the weight. less than 50, 50 to 90, 91 to 130, 131 to 170, and more than 170. Patients who come under the category of more than 170 kilos are given according to the weight. So it's 0.6 milligrams per kilo per day for enoxaparin, which is the most commonly used drugs. The postpartum, the management should continue for VTE, 7 days of thromboprophylaxis for the intermediate risk patients, and if additional factors, you consider it for longer duration. And for the very high risk category, you can continue it. You need to continue it for 6 weeks of thromboprophylaxis, according to a Norwegian study. Several weeks are needed to return to the postpartum stage, into the pre-delivery stage, and the early postpartum period is the highest risk interval, with the risk increasing per day. Mechanical and pharmacological methods of VT are followed, and early mobilization, hydration, and optimal pain relief helps. Now, when we encounter these patients for anesthesia and analgesia, the patient should have had prior anesthetic consultation, preferably should have a planned delivery. But in case when they need emergency delivery, we should keep these things in mind, that what is the drug used, what is the dose, the timing of insertion, catheter left in situ, and timing of catheter removal. And antepartum coagulation will also need postpartum coagulation, so accordingly our regional techniques should be timed. So these are the ASRA guidelines, which say that no later than 36 weeks we must switch to the low molecular weights or the unfractionated heparin. At least 36 hours before induction of labor or C-section, we convert the low molecular weight to unfractionated. Heparin should be discontinued 4 to 6 hours prior to planned delivery. Prophylactic BD dose is not a contraindication for neuraxial anesthesia, but we need increased risk vigilance for thrice-a-day dosing. And we avoid neuraxial techniques for more than 1 to 2 hours after heparin subcut, because that would correspond to the peak effect of the drug. With low molecular weight heparins, we convert to UFH at least 36 hours prior to planned delivery. With low dose, we need to wait for 10 to 12 hours after the last dose. Sorry for taking some more time. We restart no sooner than 2 hours after needle placement. Indwelling catheters are okay with the low dose. And same applies for the catheter removal as well. 10 to 12 hours after the last dose and 2 hours after the catheter removal. With high dose, we need increased surveillance because there's increased risk of spinal hematomas. We need to wait for at least 24 hours after the last dose, and we do not restart again after 24 hours post-op. And indwelling catheters are not as safe. So these are a few scenarios where you've given the low molecular weight at 0 hours. The needle placement would be done at 12 hours. And the next dose will be given at 24 hours with a 12 hours gap. If the needle is already inserted at time 0, then the first low molecular weight dose can be given at 6 hours with the It's not allowing me. And with the last low molecular dose given at 0 hours, the catheter removal is done after 12 hours, and the next dose can be given at 14 hours. Spinal hematoma should be always kept in mind. It's a very potential serious complication. Can lead to permanent neurological injury as well as death. It's in association with coagulopathy. Patients should be warned of, the carers should be warned of, and communication with the anesthetist should always be done. Last note on epidural analgesia and fever. Neuraxial anesthesia in face of infection is always contentious. Although the incidence of complications is low, we do not know the exact incidence because most of the reporting is done retrospectively or from case reports. Fever is a common symptom during labor, and 30 to 40% of these patients may land up in cesarean section. And the risk versus benefit ratio is, you need to be explained in high-risk cases. There's no reported cases of major complications. Comorbidities are associated with increased risk. It may happen due to failure of a pure aseptic technique. The risk is same as in non-pregnant patients, and theoretically, you have a higher incidence of epidural abscess because of engorged epidural veins. These are certain recommendations from the recent articles. It says that serious central neuraxial infections such as arachnoiditis, meningitis, and abscess are rare. The decision to perform a regional anesthetic must be made on an individual basis, considering the benefits and the risk. Except in the most extraordinary circumstances, central neuraxial blockade should not be performed in patients with untreated systemic infection. However, evidence of systemic infection may safely undergo spinal anesthesia if we have given a dose of antibiotic before commencing the spinal and a response to the treatment is seen. Spinal anesthesia may be safely performed in patients at risk for low-grade transient bacteremia after dural puncture. Epidural catheters should be removed in the presence of local erythema or discharge, and close surveillance, as I said, is needed for the neurological monitoring. So the thumb rule is eternal vigilance. Thank you so much. Special thanks to Manisha ma'am and Shivakumar sir for helping me across the continent, for getting my ideas sort of concise to present. Thank you.
Stay here, Pallavi. I think that you have going to have a few questions. I know it was a very vast topic, a very difficult topic to give someone with such a huge range of topics. And you covered it very well with your story. Manisha and Purnima, you want to say something before we want to?
I just wanted to find out about the obesity, amongst our delegates. How many of you would have seen patients as heavy as that? I just want to have an idea about the prevalence.
248 kilos.
Pregnant patient? No, in India. In India. 120, 140.
Yeah, I've seen up to 100.
90 to 100, yes, but more than 120, 140. Yeah. Okay.
This way? This one?
Any comments?
The one thing I wanted to say was you do get a rise in temperature after an epidural, and it doesn't always mean infection. Quite often, there is evidence that with an epidural there is release of interleukins, which can cause a rise in temperature. The only implication is that with increased maternal temperature, fetal distress is more likely. So the temperature should be brought down and the woman should be delivered as early as possible. But it doesn't mean that there is infection there.
Yeah, gone. Okay.
Yeah, we certainly use it for miscarriages and and it does, yes.
So prostaglandin related, isn't it? That's what how some of the antipyretics work. Yeah. Okay, we want to move on to the next topic, which is no pain and all the gains. Okay, so obstetric analgesia, how obstetric analgesia can be managed. Very interesting topic. Okay, and it'll be done by Arvind and Surjit, and they're going to talk about analgesia in cases of a normal labor, as well as analgesia for cesarean sections, both. Thank you, Arvind and Surjit. Yes, sir. You can do that, and just you can go forward and back if you want.
Good morning, everybody, and thank you for asking me to talk about this. So, labor pains. Some people say, why bother? After all, a woman goes through labor maybe twice or thrice in her lifetime. It's one day of discomfort. So what is the big deal? What's the fuss all about? in the past, people considered that it was wrong to take away the pain of labor. The quote in the Bible which says, it's projected over there. In our country, women of the previous generation, more the mother-in-laws than the mothers, often say, we went through labor twice, thrice, 5 times without all of this. So what's changed now that, these newfangled things are required? So they are suspicious, they are skeptical. And some of the husbands, they say, my wife can tolerate pain. She doesn't need any pain relief. I think if you don't have a uterus, you're not entitled to have an opinion about this. The Romans called it poena magna, or the great pain. And I think it's rightly been said that this is possibly and probably the worst pain that a woman will experience in her life. So if we have the means to take it away, and she wants you to, I don't see why you shouldn't. Now, this is folklore. I don't know if it's true, but allegedly and apparently there was a tribe which used to do this in Mexico. Looks quite terrifying, but I don't know how true that is. Going on to the ways in which we can provide analgesia, these are the 4 broad categories. As far as non-pharmacological methods are concerned, I think it's primarily by placebo and maybe an element of distraction to keep the patient's mind occupied. So in my institution, we have a hypnotherapist, we have a birth instructor, and we do have patients who come in saying that they want a natural labor. And so they have a laminated sheet of paper, which is their birth plan. And oftentimes all of this goes out of the window when they get their first real contraction. So I'd just like to quote what one of my patients said. She had planned for a natural labor, and she quickly changed her mind. So she said that, they told me I'm imagining it, but you take away that imagination. I think that sums it up quite well. We'll be talking mainly about regional anesthesia. So what are the benefits? First and most important is the excellent analgesia that it affords. And you have an alert, awake patient who can participate in her labor and have a pleasant recollection of it. And it does reduce catecholamine levels and blunt the hyperventilation cycle that occurs in normal labor. And of course, it's available for use should you end up in a section. Having decided on a regional technique, the choice between a combined spinal epidural and an epidural. I think the CSE scores over an epidural in at least 2 situations. One is early in labor, for example in latent phase, where you feel that you have a long way to go before the delivery. And giving that intrathecal shot keeps her comfortable for 2 to even 3 hours and reduces the overall dose of local anesthetic that you end up using. We do know that local anesthetics have a cumulative effect, and after a long labor you might have an element of motor weakness, which is unnecessary and unpleasant, disconcerting for everybody, the patient, the anesthetist, and the obstetricians. So this prevents that. And the other situation is late in labor, 6-7 centimeters dilated, when they are uncomfortable, uncooperative, unwilling to help you do your job. So giving them that quick intrathecal shot gives them immediate relief, and then you can put in the epidural in a relaxed manner. So what are the disadvantages of a combined spinal epidural? I think there is just one real disadvantage, and that is the fact that we are left with an untested catheter. So it might sometimes happen that the spinal wears off, and then we start using the epidural and it doesn't work, and we end up needing to resite it. Or the other situation is where the patient ends up needing a cesarean section, and oftentimes we all know obstetricians tend to overplay the urgency of the surgery, and they request a general anesthesia for time constraints, and we convince them that 10 minutes that we take for the epidural to work is the same 10 minutes to drape and paint and catheterize. And at the end of that, if it doesn't work, it's quite unpleasant. But that apart, I think it's all good. I think CSE is the way to go. Having decided on an epidural, when do you